COVID-19 is that when you learn more, you realize that there are much more to learn. There are new aspects of the disease and its complications, and there are a lot many things we might not know, and also we might miss. And now look at this topic we have chosen today. Uh, it is the discharging patient, or the patient upon discharge. What are the problems we encounter with the patients who are being planned on discharge, and what advice we have to give them on discharge, and when to review, and which patients need to be reviewed. I think today's speaker is going to tell you about all and answer your questions. So we have our speaker today, very competent and clever physician, in fact, chest physician of Kandy Teaching Hospital, Dr. Amila Rathnapala is going to talk to you about the topic we have given today. So a little bit of Amila. He has a quite impressive academic career behind him. He had his MBBS with second-class honors with distinction in pediatrics from the University of Colombo. And after completing the MD medicine course, he went to John Radcliffe University Hospital in Oxford to complete his overseas training in respiratory medicine. And after coming back to Sri Lanka, he started his work at National Hospital Kandy as a consultant respiratory physician. I'm sorry I missed this bit. He obtained membership of Royal College of Physicians and specialty certificate in respiratory medicine during his stay in the UK. And in addition to that, he is the brother of Dr. Amila Rathnapala, who is our own consultant nephrologist at General Hospital Padulla. So it seems the academic brilliance, dedication runs in families because they have done extremely well in their chosen fields. So congratulations to you for your achievements, first of all. And then we will, Amila, it's a pleasure to meet you after a while. So over to you. Take over the proceedings, please.
Thank you so much, Iranta. I mean, it is a pleasure to see you after a long time, and I must thank the Uber Clinical Society for the invitation and to discuss about this COVID-related issue. So today we are going to discuss about COVID upon discharge, and could you please tell me, can you see the screen?
Yes. Yeah, it's very clear. Yes.
Yeah. So today we are discussing about COVID upon discharge, and these are my disclosures. First of all, I'd like to start my presentation with this famous singer, I think known to everybody, Sunil Perera, who died after about 2 days following discharge. So therefore, this triggers everybody that your discharge has to be planned very well to prevent these incidents. Yeah. So generally speaking, actually about 1 in 10 patients who have been discharged will readmit usually within 2 months. But these are figures from America, actually. If you consider other areas like UK and some developing countries, the figures are more. And roughly, we are talking 1 in 10 patients who have been discharged will readmit within 2 months. So my objectives for the discussion today, I'll be discussing basics about COVID and lung injury, because this might be a kind of a repetition. However, that it's very important to understand the injury mechanisms, pathophysiology before planning discharge and before discussing about the post-COVID sequelae. And then I'll be discussing about the readmission and how to plan the discharge and then arranging follow-up, as well as I'll be briefly touching about the post-COVID syndromes. So basic of acute COVID-19, as you know, there's a two hits hypothesis. There is epithelial injury caused by COVID-19, and as well as there's endothelial injury caused by COVID-19. So there's a simultaneous epithelial as well as endothelial injury done by the inflammatory cascade due to COVID-19. As you know, this SARS-CoV-2 virus, when it enters the epithelial cells through the ACE2 receptors, it results in a huge inflammatory cascade. And it has been studied, as you know, this has been compared with influenza pneumonia. And the total cumulative dose of cytokines exposed to a particular patient with COVID-19 is about 3 times more than the usual influenza pneumonia. And this inflammatory response is persistent for months, sometimes years. Therefore, this COVID, acute COVID, has been divided into 3 phases, as you all know. The early viremic phase, or phase 1, and then the phase 2 is the pulmonary phase, where you see the infiltrates of in the lung imaging. And in first stage, that is 2A, there won't be any hypoxia, even though there are radiological evidence of pulmonary infiltrates. And in stage 2B, you know, there are pulmonary infiltrates, as well as patients are hypoxic. In stage 3, we know that patients are in ARDS or SIRS or cardiac failure, and there will be a kind of a significant systemic hyperinflammation. So therefore, when you postulate the hypothesis regarding this damage to the organs, there is a hyperinflammation which lead to epithelial injury and which lead to structural lung damage or structural organ damage. This is contributed by the nosocomial infections, because we are giving a lot of immunosuppressions, immunomodulators, as well as a lot of antibiotics. And then this is further aggravated by our ventilator-induced lung injury, as well as self-inflicted lung injury. And in addition to that, there's endothelial damage, which results in endotheliitis, as well as thrombosis and agenesis, which results in breakdown of the alveolar barrier, which results in non-cardiogenic pulmonary edema. This is further aggravated with dehydration. So both this epithelial damage as well as endothelial damage, they result in acute COVID. And as you know, 20% of the patients, unfortunately, they succumb to the disease. And then about 30 to 50% will recover. But unfortunately, about 30 to 50% of the patients remain symptomatic with their post-COVID syndrome or long COVID syndrome. Then I'll be discussing about these readmissions. This is a study published in JAMA, a study about 132 hospital admissions. And this is one of the earliest study which has been evaluated readmission and death following initial hospital discharge. So there are 132 hospitals are involved, and they have concentrated on admissions from 1st of March 2020 to 1st of June. And then they compared these cohorts with non-COVID pneumonia as well as heart failure. And they realized, actually, with the modeling, they compared this COVID pneumonia readmissions with non-COVID pneumonia as well as heart failure readmissions. This readmissions has been carried out for 60 days following the discharge among the survivors of COVID-19. The results are striking. For example, about 2,179 index hospital admissions were there, and then majority were actually did not require any ICU, but about 31% required ICU and 13% required invasive mechanical ventilation, and 14% required vascular support with vasopressors. And within 60 days of discharge, about 354 patients, that is roughly about 20% who survived, readmitted within 60 days. But unfortunately, about 9.1%, that is nearly 10%, died during this readmission process. And so if you combine them together, roughly about 1/3, about 27% of the patients actually either readmitted or died after discharge. Then they remodel these readmissions and compared with this non-COVID pneumonia, as well as they compared with cardiac failure. So as you can see here, I mean, initially within first 10 to 14 days, the readmissions and death were significantly higher in COVID-19 compared to non-COVID pneumonias. But when it comes to about 60 days, that is about 2 months later, the discharge, and the admissions rate are quite low than the non-COVID pneumonia. It is quite similar to cardiac failure as well. In cardiac failure, that compared to the cardiac failure in COVID-19, as you can see here, there's significant readmission as well as death were following COVID-19 discharge compared to cardiac failure. But at the end, when around 60 days, that readmission rates are less in COVID-19 compared to our cardiac failure patients. So therefore, it gives a big message to us that the first 2 weeks following the COVID-19 discharge is a crucial period where they can die or readmit. Then actually, this again, they have analyzed, I'm sorry about this busy slide, but I just want to concentrate about few factors here. Then they have analyzed about the demographical as well as other data about these patients who has been readmitted or died after readmission. So what they found is actually there's a significant association between the increasing age as well as duration of the hospital stay. So if they are elderly, there's a high risk of hospital admission, as well as if the patients are staying for more than 7 days in the hospital, again, there's a high risk of hospital readmission. So these factors has to be considered when you are discharging a patient. And this study, again, actually, this again discuss about post-COVID syndrome in individuals admitted hospital with COVID-19. It is a retrospective cohort study which has been published in BMJ, and that is about the NHS. There are several hospitals in NHS. They have studied about 86,000 patients who had been readmitted following their discharge, and then they have excluded about half of the patients and analyzed about 47,000 patients in this study. So here they found that they have followed up about 140 days. Nearly 1/3 of the individuals who were discharged from the hospital were admitted within 140 days, as well as about 1 in 10 died after discharge. So these and also these events are occurring about 4 to 8 times greater than compared to the mesh groups, so mesh with the other pneumonias. So we know that COVID-19 results in more readmissions and more deaths following discharge compared to the other pneumonias, as well as other cardiac conditions. So these are the actually kind of comorbid conditions that they had. They have analyzed regarding these readmissions. Most of the patients were diabetes who had these events, and most of the patients had cardiac events and chronic kidney disease as well as chronic liver disease as expected. So patients with comorbid conditions, particularly diabetes and cardiac diseases, they are very high risk for these events, readmissions. And here they have compared with other ethnic groups, for example, non-white and white people. And we found that smaller ethnic minorities, Asian as well as African, they had a high rate of readmission and death. And there's no significant difference between the sex, actually, the males and females, there's no significant difference. But however, the age, actually, the age of certain individuals less than 70 who had been admitted more frequently to the hospital in United States, sorry, in UK. So with all this information, now we know that within 40 days of discharge, there's a very high risk of readmission. as well as more elderly people could readmit, and patients with comorbid conditions could readmit, as well as if there's a hospital stay more than 7 days, that they can readmit and they can die after discharge. So we have to plan our discharge with all this information in hand. So what are the objectives of discharge? So there are 5 basic objectives that we should discuss, or we should identify in a patient before discharge. The first of all, we have to identify high-risk groups for readmission as well as death following discharge. And then you have to identify the medications to continue, identify the comorbidities, and then optimize them. And then you have to time the review very well. And then at least, actually, I mean, we have to discuss about, or we have to think about the infectivity of that particular individual to the community as well. The first objective, identify high-risk groups for readmission and death following discharge. So how do you do that? We know from all these studies, elderly, patients with comorbid conditions, patients who have been hospital admitted for more than 7 days, and patients who are immunosuppressed, especially post-KT patients with interstitial lung disease, for any other reason, if the patients are on immunosuppression, and they are high risk of readmission as well as death following discharge. Then identify the medications to continue. I mean, if you go to a prescription of a patient who has been discharged with COVID-19, I mean, you can clearly see that most of the patients are on polypharmacy. There are multiple medications. Most of the patients, about 99% of the patients are on steroids and multivitamins and so on and so forth. We'll discuss about this. So I'll discuss briefly about the corticosteroids in COVID-19. So remember, the steroids in COVID-19 is a double-edged sword. You have to use this very carefully, because if you use this inappropriately, the mortality as well as morbidity will go up. So if I come to the indications in COVID-19 for steroids, there are 2 clear indications, evidence-based indications. Number 1, if the patient is having COVID pneumonia, either stage 2B, where the pulmonary phase with hypoxia, or stage 3, that is your hyperinflammatory phase. So these are the stages in acute COVID pneumonia we consider steroids. As well as if the patient is having post-COVID ILD, it could be either early autoimmune or it could be early fibrotic. So whatever the type, that there is an evidence-based place for steroids. But apart from these indications, when you are giving steroids, it has to be rationalized before giving steroids. So if you consider this COVID pneumonia stage 2B and 3, and the standard of treatment is intravenous or oral dexamethasone 6 mg daily for 10 days, as we all know. This came from one of the first class clinical trial, Recovery, and then it has been studied in many other trials. But there are kind of individual, or there are small studies about higher dose of dexamethasone and methylprednisone as well. But for the time being, we consider dexamethasone 6 mg daily for 10 days or until the discharge, hospital discharge, is the standard treatment. But if there is persistent hypoxia beyond 10 days or beyond your steroid therapy, these patients has to be individually evaluated for their particular etiology. Why these patients are hypoxic. For example, if the patient is having post-COVID ILD, or if the patient is having ongoing infection, could be typical or atypical infection, or it could be a patient is having either pulmonary thrombosis. So that has to be evaluated individual case by case before continuing your steroids after 10 days. So that is very important. And then this study, I'd like to highlight this study. This is one of the interesting study published in International Journal of Medicine and early this year. A study conducted in Portugal, and it studied about steroid use, and it is a retrospective study. In the first study, as you can see here, that in this scatter plot, the increase cumulative dose of steroids. So your x-axis is the cumulative dose of steroids. Basically, they are using methylprednisolone equivalents. And then your y-axis is about mechanical ventilation days. So how many days of mechanical ventilation or duration of mechanical ventilation. As you can see, that when the dose of cumulative dose of steroid is going high in your x-axis, the number of hospital admission days or ventilated days were increased. And then with this following this further analysis about this cubic spine analysis, or what you call, and here we found that there was a sine wave correlation between steroids and the number of mechanical ventilated days. For example, when the steroid is going up to methylprednisolone equivalent about 500, 560, the number of hospital admitted or mechanical ventilated days will be going down. But when the doses are going up, the number of mechanical ventilation days are going up gradually. So there's a U or sine wave relationship. That means there's a beneficial dose and duration. But when the cumulative dose is going up more than a certain amount, and there's no particular benefit, the number of hospital admission or number of days in the hospital or in the ICU will go up significantly when they're on larger dose of steroids. So please use your steroids very carefully, and remember that the patient are having evidence of post-COVID ILD or any other indication, that you should specify that and continue steroids during the discharge. So the post-COVID ILD, I mean, that is the next indication for steroids. I mean, we should define the clinical context of post-COVID ILD, and please arrange a HRCT if you're suspecting post-COVID ILD, and then identify what is the pattern of post-COVID ILD, whether it's early autoimmune pattern or a fibrotic pattern. And if it is early autoimmune, you might give prednisone about 0.75 to 1 milligram per kg per day. And if it is early fibrotic pattern, you may give prednisone about 0.5 milligram per kg per day. And then you should arrange a follow-up CT and then assess the escalation of immunosuppression or considering antifibrotics. So this is a rough plan about post-COVID ILD. So this is another indication for steroids. So apart from these two indications, and there's hardly any place for steroids in COVID-19 unless there's another indication. When it comes to anticoagulation, that is a controversial area, especially on discharge. And I must discuss about these three clinical trials. There is a multi-platform clinical trial, RENAC-CAP, Active 4A and ATTACC, which studied therapeutic versus prophylactic dose of anticoagulation in patients with critically ill or patients with moderate COVID. So these two studies has been published in NEJM, and the first study about the moderate ill patients with COVID-19, what they found is actually there are significant proportion of patients who were organ support free for more, I mean, the days of organ support free days were higher, significantly higher in the patients who are on therapeutic dose. Remember, these are the patients with moderate disease. As you know that these patients were receiving oxygen up to the level of non-rebreather mask, and these patients were not on high flow oxygen or non-invasive ventilation or with mechanical ventilation. And then the usual care was about 76%. So basically, patients who are on therapeutic dose anticoagulation did very well when they are moderately ill. And then this study actually published again in JAM. This is about the patients who are critically ill, who are on either therapeutic dose of anticoagulation versus usual care prophylaxis. What they found is actually patients were on prophylaxis dose of anticoagulation, and the organ support free days were higher. But however, they have not achieved the statistical significance in this critical group. As you can see, this odds ratio is going beyond 1. But so clearly we have evidence for anticoagulation in acute COVID pneumonia. But when it comes to post-COVID or post-discharge anticoagulation. And this is highly debated, whether we should continue anticoagulation or not. Right. The current consensus is actually routine administration of oral anticoagulants in all patients with COVID-19 at the time of discharge is not recommended. So we do not have any evidence to recommend anticoagulation for all patients with COVID-19, but you might decide regarding the post-discharge thromboprophylaxis or anticoagulation after assessing individual patient. That is very important. I'll discuss further. So there are reviews, there are clinical trials going on post-discharge anticoagulation, but for the current evidence, that most of the evidence are expertise-based, and this study review published in BMJ. Patients who are at high risk of thrombosis, for example, if the patients are elderly and if the patient had any past history of pulmonary embolism or any history of a deep vein thrombosis, or if the patients are having malignancies, or if the patient has a prolonged immobilization, ICU stay for about more than 7 days. So these group of patients, you might consider anticoagulation. In my experience, we have one patient actually who's on apixaban. So you have to individualize this post-discharge anticoagulation, and you should not routinely give it, but when you're giving it, the evidence is not for vitamin K antagonists. For example, your routine warfarin therapy is not the first-line therapy for these patients. The therapy is DOACs, or that is your directly acting oral anticoagulants, that is your apixaban or rivaroxaban. So these are superior to vitamin K antagonists or your warfarin when you're giving post-discharge prophylaxis. So therefore, in our practice, it is available in the private sector, but it's not available in the government sector. Therefore, we can't routinely give them, but if it is indicated, you might discuss with the patient regarding the indications. The duration is not yet studied, but at least we have to give for about 30 to 60 days according to the current evidence. Then the next most important drug that we should prescribe upon discharge is oxygen. This patient requires oxygen. So most of the patients had COVID pneumonia, and you have to assess their oxygen status before discharge, and that is very important. Yeah, so when you consider moderate to critical ill patients, when you're planning to discharge, you should assess their resting saturation levels. And if the resting saturations are less than 95% on air, please do arrange an arterial blood gas analysis and identify if the patients are in either type 1 respiratory failure or type 2 respiratory failure. If it is type 1, most likely the patient is having a parenchymal or interstitial problem. So we might have to arrange HRCT and identify whether there are any underlying interstitial lung disease, and then manage accordingly. And you might have to consider long-term oxygen. If the patient is having type 2 respiratory failure, you might have to diagnose undiagnosed COPD or any obstructive diabetes. And we commonly see patients with obesity, hypoventilation syndromes, and obstructive sleep apneas when they are hypoxic. So please arrange a blood gas and then assess whether they are in type 1 or type 2 respiratory failure. And depending on the type of respiratory failure, please identify the etiology and then manage accordingly, and then consider long-term oxygen at the time of discharge. But if the resting saturation is more than 95% on air, so in that case, you have to arrange this MEDT or minimal exercise desaturation test. And I'll discuss briefly about this MEDT, but if MEDT is positive, again, you should identify the etiology, because this could be airway disease or it could be interstitial disease. You have to arrange again a blood gas and see, as well as whether they're in type 1 or type 2 respiratory failure. And most of the time, these patients need lung functions as well as HRCT. And then if the recovery time, that is actually if the time to recover from hypoxia If it is more than 2 minutes, in that case, you might have to consider ambulatory oxygen. So these patients must be referred to a respiratory colleague, and we'll arrange these tests, as well as we might have to arrange ambulatory oxygen. And if the MBT is negative, actually, that is, if there's no desaturation on exertion, in that case, you can discharge these patients with a proper follow-up plan. I think you should be very familiar with this situation. If the patients are hypoxic, there's one pathway. If the patients are not hypoxic, you have to arrange MBDT. And then if the MBDT is positive, you might have to again identify the etiology and then consider ambulatory oxygen. You can arrange with the help with the respiratory colleague. So this is MBDT technique. I mean, this has been published by the Ministry of Health, Sri Lanka. The step one is to use finger pulse oximetry to record baseline oxygen saturation. And then step two is to ask the patient to stand and sit for at least 10 to about 8 to 10 times, and at least take about 30 seconds to be seated before standing up. And then step three, to observe the pulse oximetry for at least 90 seconds. And most of the time we see that we put the pulse oximetry and then we observe their saturation within about 10 to 15 seconds. And once they're normal, then we remove it. But still, that we have been identified that the saturation could go further down even after 30 seconds. So it's very important that you have to at least keep your pulse oximetry for at least 90 seconds, 1.5 minutes at least. And if the saturation drops below 96% or saturation drops more than 3%, that is very significant. And remember that we should not do MBDT or minimal excess desaturation test for patients who are hypoxic, or if the patients are having suspected of angina or any physical ailment. The third aspect of our discharge planning is to identify their comorbidities and optimize them. That is important. So remember that most of the patients actually with severe COVID-19, they have comorbid illnesses. Most of them are having diabetes, cardiac problems, CKD, or organ transplanted, immunosuppressed. So therefore, you have to reassess about their comorbid conditions before discharging. For example, patients with diabetes has to be evaluated and their glycemic control should be achieved. And patients with ischemic heart disease, you should assess and identify whether there's an ongoing ischemia or not. And the patients with CKD should make sure that patients are not in acute or chronic CKD at the time of discharge. And then most commonly, patients with immunosuppression, especially post-KT patients, we know that their immunosuppression levels are reduced during the severe COVID pneumonia. And most of the patients with severe COVID pneumonia, we stop mycophenolate and we have tacrolimus. So make sure that these patients are back on their immunosuppression at the time of discharge. Or I mean, if you are not planning to restart immediately, at least you should have a plan to restart this immunosuppression or re-escalate the immunosuppression. So before discharging, you should have a thorough idea about their comorbid conditions and you have to consider their management. And then the next most important aspect is timing of the follow-up. So when to see these patients. So when you're discharging a patient, you know that we have high-risk patients that, as I discussed earlier, patients who are elderly and patients who had multiple comorbid conditions, patients who had hospital stay for more than 7 days, and patients who are immunosuppressed. So these are the high-risk patients for hospital readmission and death. So these patients need to be reviewed within 2 weeks. So as I discussed in the previous study published in JAMA, the 2 weeks is the most critical time period that these patients can readmit and then they can die within these 2 weeks. So these patients has to be reviewed within 2 weeks. And the low risk patients, most of the patients who are mildly symptomatic, even about virtual or phone call is enough within 4 weeks. And then you might decide to review them within about 2 months. But the focus should go to the high risk patients. And we should remember review them within 2 weeks. And the last but not least, we should assess the infectivity. I think our ministry guidelines giving a lot of prominence for this infectivity, but as clinicians, I think, yes, we should consider, but not significant at this point, because when the patients are critically, their infectivity levels are going down drastically. So patients with mild to moderate illness, according to the ministry guidelines, you know that if they're clinically fit, within 10 days that you can discharge the patient, and you don't have to arrange further testing. And severe or critically ill patients, you might have to consider discharge after 14 days. But if the patients are immunosuppressed, even asymptomatic or symptomatic patients, if they're clinical fit, you can consider discharge in 14 days. But they are recommending actually doing a PCR at the time of discharge. And if it is negative, or if the CT values are more than 30, you can consider. But alternative, I think most of the time what we do is actually we do if the CT value is less than 30, we may consider doing 2 rapid antigen tests within 24 hours apart and consider discharging. So basically, these patients actually can step down to intermediate centers, or if you want to keep for 21 days, but basically after 14 days, you might consider discharging this patient if their RAT is negative consecutively for 2 times within 24 hours. I'll briefly discuss about the post-COVID syndrome because there is such a common entity. And the definition, we don't have a global definition for the time being. Some they consider long COVID and some consider post-COVID, but whatever, for the time being, the consensus is actually that post-COVID is after 4 weeks. Within your 4 weeks of illness is your acute COVID pneumonia phase. And then after 4 weeks to 12th week, that is your acute post-COVID period, that is roughly about 3 months. And then from 12th week to 24th week, that is from 3 months to 6 months, is your long post-COVID phase, or your phase 2. And then your after 6 months, that is your persistent post-COVID. So basically after 4 weeks, it is post-COVID. And if it is 12 to 24 weeks, that is long post-COVID. And if it is more than 24 weeks, that is persistent post-COVID. Any of your organ system can be affected with post-COVID syndrome, and the commonest being fatigue, decline in quality of life, muscular weakness, and joint pain. And then your respiratory system is about 30% of the time it is affected with dyspnea, cough, and persistent oxygen requirement, and anxiety, depression, sleep disturbances, post-traumatic stress disorder. Brain fog and headaches are really common among these patients. Most of the patients, they have palpitations, chest pain. So there is significant list of symptoms. If you consider the symptom list, as you can see, the fatigue being the commonest, and then the breathlessness, and go on, chest pain, joint pain, vision problems, cough, loss of smell, and dry eyes, and so on and so forth. So there's a significant proportion of patients, so 30 to 50% of the patients with COVID pneumonia can have either one or combination of these symptoms. So there are 3 pulmonary syndromes that we can identify in this post-COVID, and commonest is the post-COVID bronchial hyperactivity syndrome, and then they have post-COVID ILD and post-COVID pulmonary hypertension. So these patients has to be evaluated by specialties. So again, I'll briefly touch about the post-COVID clinics and setting up a post-COVID clinic. I must say that is really challenging, but still it is possible. And the most important aspect is it should be multidisciplinary, because most of the patients who are coming to us with breathlessness, they commonly have anxiety, they commonly have sleeping issues. And most of the patients who have been in ICU, isolated for about several days and weeks, they are having post-traumatic stress disorders, and most of the patients are having tachycardia. So the beauty of a post-COVID clinic is it should be multidisciplinary. The most challenging feature, most common challenge that we face is actually when we find these patients are having psychological symptoms or neuropsychiatric problems like brain fogging and all. When you do a psychiatric referral, and they do not present there because they think that we are referring because they are having some sort of a psychiatric issue. But so rather than we are referring here and there, I think one from the psychiatric clinic and one from your cardiology clinic should be combined in a post-COVID clinic. I must say, I mean, we are still working on this, but it is really challenging to get other specialty to a common platform to evaluate these patients. The problem is actually that these people will not present to the other clinics because that I mean, they are already traumatized with COVID. So if I summarize the discharging criteria or how to assess the discharge, the first and foremost important step is to identify the high-risk groups for readmission and death. Remember that it's quite common in America, that is 10%, in UK it's about 1/3, in our part of the world it is significantly higher. And remember, it's about again 9 to 10% of the patients can die during the readmission. So you have to identify the high-risk groups. If I recapitulate, they are the elderly groups, they are comorbid conditions and prolonged hospital stay, or with persistent hospital admission or hospital stay for more than 7 days. And then please identify what are the medications to continue. No point of burden them with multiple these vitamins and all. You should identify whether the patient needs steroids or not, whether the patient needs any anticoagulation, most of the time no, and whether this patient needs oxygen or not, that is very important. And then please identify their comorbid conditions. There may be newly diagnosed comorbid conditions like diabetes, and please optimize them. The patients might be immunosuppressed, you might have stopped immunosuppression temporarily. Please assess this patient whether you can restart the immunosuppression again. And then timing. Patients with high risk factors for readmission, they have to be reviewed within 10 to 14 days in your clinic, because that is the golden time that you have to prevent, that you will prevent a death or readmission. And then think about the infectivity as the last option. So I'll finish my presentation here, and I'll be finishing this COVID-19 motto. I think I always discuss about this. The COVID-19 treatment, you have to identify the right treatment in right patient and right time, and for the right outcome. No point of giving every drug which is coming out from various studies to every patient. So you have to identify the patient and then consider proper treatment for a proper outcome. Thank you so much.
All right. Thank you, Amila, for that comprehensive, very informative talk, which is very usual of you. To start with, I made a couple of interesting observations. Is there a direct correlation between the severity of the disease and the rate of readmissions and death? Like, let's say, mild, moderate, severe disease. Is it a thing that the severe or moderate disease people are readmitted more than the people with mild disease?
Yes. Thank you so much for that question, Hiranta. And so, I mean, from these studies, actually, we know that patients who had more critical illnesses and more severe disease, actually, they are admitted more, and especially they have assessed this hospital duration, so hospital stay. So if the patients are staying in the hospital for more than 7 days, so most of the time in other countries, they are not keeping asymptomatic patients in their hospitals. So these patients are either moderately or severely patients. So if the hospital stay for more than 7 days, these are the people that they will either readmit or die.
Right. Basically, the people who stay like 7 days or more are naturally severe disease people.
Yes.
Yes, that's very clear. And the other thing is about the exercise, the desaturation testing. I don't know, I made this observation, and so as some of the medical officers from our intermediate centers. where the mildly or the people with mild disease also show some desaturation, and they kind of transfer those people from the intermediate centers to our hospital. What might be the phenomenon regarding this? I mean, people with either probably asymptomatic or mildly symptomatic people upon discharge, when doing the desaturation test, it becomes positive.
Yeah, I mean, again, thanks, Sinath. So we have observed even that, I mean, patients who are asymptomatic or mildly symptomatic, and they are presenting later, or when we're discharging these patients, sometimes most commonly what we see is actually these patients present to us saying that they're having some sort of dyspnea also, and when we do the MEDT, that we find it is positive. Then actually we do the routine evaluation. So my experience, as well as, I mean, we are studying on this, and this is the syndrome that we are talking about, post-COVID bronchial hyperactivity. So they do not have parenchymal disease. Their lungs are fine, but if you do X-ray on them, there is evidence of air trapping. So the diaphragms are flat, hyperinflated. So this is the group that we see that they are having airway constriction or post-COVID bronchial hyperactivity. And so therefore, these patients, in my experience, actually, I mean, ideally, you should do a lung function test. Yes, we are doing. I'm not sure whether we can do it in each and every center, but still, it is important to do a lung function test to see whether they are having bronchial hyperresponsiveness or not. So if they are having bronchial hyperresponsiveness, that means that if there's reversibility in a lung function, they will respond nicely to inhale corticosteroids. And there's another group that these patients that they are not responding to, they are not having reversibility. So they are having persistent small airway obstruction. So that group is responding nicely to the bronchodilators, that is your tiotropium or ipratropium, long-acting bronchodilators. So I think this area of evolution, I mean, we are also studying on this, and we are collecting kind of samples of these similar categories of patients. So that's a phenomena that we see, that is post-COVID bronchial hyperactivity, and some are having asthma-like features, that is your patients with reversibility, and some are having COPD-like features. So this is a phenomena that we see in COPD.
Okay, so let's see what's on the question segment here from the audience. There are not many accolades and thankings.
Hiranta, can I ask a question?
Yes, please. Dr. Hiranta Pathiratna, our own chest physician, is online. Go ahead, Hiranta.
Hi, Amila. It's a great
Hi,
lecture.
Hiranta,
Thank you.
nice to see you.
Hi, Amila. Yeah, now it's like, when do you consider starting antifibrotics rather in your practice?
Yeah, so when I'm talking about antifibrotics, that there are 4 clinical trials going on at the moment for nintedanib, that is in UK and other European countries. So we don't have first-line data. So what we do is actually in our practice that when the patients are persistently hypoxic beyond this set time of steroid use, that we do a HRCT test and identify whether they are having early autoimmune features or early fibrotic features. For example, if it is organizing pneumonia, or whether there is fibrotic NSIP or fibrotic NSIP OP pattern. So in that case, first line of treatment is steroids, and we consider steroid. But if then we reassess these patients within about 4 to 6 weeks, sometimes about 8 weeks, and if the patients are persistently symptomatic, irrespective of the steroids, that means there's some degree of progression in the fibrotic phase in the second CT scan, that we may consider starting nintedanib or pirfenidone. Actually, we have 2 patients on nintedanib, and there are several patients on pirfenidone. But presence of fibrosis per se in the first CT scan might not be the indication for antifibrotics. But first line is the steroids, that as we know, we have evidence. But if there's persistent symptoms and if the patients are having persistent hypoxia and progression in their fibrosis, irrespective of the steroids, that we can consider antifibrotics. But the trials are going on for the time being, whether we should start initially at the onset of this early fibrotic ILD, but we are not doing because that we have very limited resources.
Yeah, and one other question I have now, when do you consider steroid sparing agents?
Yeah, so that is, that is again, actually we consider predominantly for this, what you call this early autoimmune group of ILDs, that is the organizing pneumonia and NSIP OP patterns of ILD. And so first line, again, the treatment with steroids, and we do the second CT scan in about 8 to 12 weeks time, sometimes about 6 weeks if patients are not responding. And then we consider starting our second line agent, commonly mycophenolate if there's evidence of progression in the ground glass or consolidation. So basically, if there's persistent inflammation, we may consider starting second line agents. And if sometimes that patients are not tolerating steroids properly, in that case, we may start second line agents early. And we have 2 cases actually for the time we have to go to the extent. We have very severe inflammatory disease, and we have gone in 2 cases to the extent of cyclo. And so both these patients are doing very well. So sometimes we might have to go up to that extent, but I always do autoimmune profile on these patients to see whether there's any other autoimmune activity leading to their ILD before I start second line agents.
Right. Thank you. Thanks a lot.
Okay.
Okay, Amila, one bit of a question. It's not related to today's topic, though. How about the new drug or the antiviral called molnupiravir, which seems to be promising in the early studies, and I think they are recommending in the US. What is your view on that?
Yeah, actually, I mean, first of all, I mean, that drug is actually, they have used for influenza, and now they have studied for COVID, and in the early phase that they found there's a 50% reduction in hospital admission. But I have seen the press release. I mean, still the results are not peer reviewed. So as a scientist, I think we should wait for the peer reviewing process. And it's a press release. So I think it is a very promising drug, and I think we might kind of be aware, might change our overall clinical outcome. But still, I'll be really patient until I see the peer reviewing process, because it is still a press release, and I'm waiting for the peer review.
Okay. There's a question coming up from the audience. It's from Dr. Denita Shantakumar, our microbiologist. Have you come across post-COVID patients with fungal lung infection or TB reactivation?
Yeah, so fungal infections associated with COVID, I think that is a separate kind of topic that we should discuss. And now our burden is fungus. So basically now we are having in our ICU in Kandy. So we had 4 patients with mucormycosis, 1 died, and at the moment we have 1 patient in mucormycosis. So the mucormycosis is there in patients with COVID, and that is, we don't know exactly the COVID is causing it, but you know that there are so many other risk factors. But that is one of the burden that we see among patients with COVID positive. Still, we don't know the etiological aspect of it, or whether there's any cause effect association between COVID and mucormycosis. But there is a dream, because that these days we don't have liposomal amphotericin in B as well. So it's a dream having mucormycosis patients. So we are having a lot of mucormycosis cases nowadays in Kandy in our ICU. At least we have 1 death now. So then there is one, and then aspergillus. So aspergillus is quite common, and in our patients with, especially with COVID pneumonia, who are on high dose steroids, as well as on patients commonly they are diabetes. So I mean, we have actually collected some of the data of their galactomannan, and we have seen certain proportion of patients actually they're having very high serum galactomannan levels. So we routinely, I mean, in our practice, so as I said, when the patients are persistently hypoxic on day 10, we are doing certain set of investigations. One is galactomannan, and if the PCT and all are negative, so and then we consider antifungals routinely when they are persistently hypoxic, irrespective of their disease status. So that is quite common actually. And TB reactivation again. I mean, TB reactivation with COVID pneumonia, I mean, there are few cases, but not that common as fungal infections. I must say, I mean, we commonly see fungal issues than TB in our patients.
All right, Amila, in the absence of further questions, we will conclude our sessions. Before that, I'm immensely thankful to you, Amila Rathnapala, for your great contribution. And we wish you good luck in your future endeavors. And I also thank UWA Clinical Society and the General Hospital Badulla for conducting the sessions, and hoping to meet you in another similar sessions in the near future. And saying goodbye to you all, we'll wrap up the session. Thank you and take care.
Thank you so much. Thank you so much.